Hello students, now I am going to discuss a case study of a stroke. So in which I will tell you what was the scenario in the history and the medical history and how the patient came and admitted to the hospital, and we will be discussing some questions regarding that. Okay. So a 68-year-old male admitted in the emergency following a collapse at the home. So in history, his wife stated that he was found in the garden at home. He was drowsy and uncommunicative at that stage, and she said he had vomited previous to that instance. So she thought he had suffered a collapse several hours previously. So in the emergency, immediately after the admission, they have taken CT scan that shows an infarct in the right middle cerebral artery. And they have taken a chest X-ray. So in that there was a patchy shadowing of the right base of the lungs. Okay. So on arrival to the emergency, the patient was drowsy and appeared to able to respond to only basic commands. And he was not able to recognize the stimuli on the left side of his body. So you can come to a conclusion that what was the effect happened because of that collapse. So left-sided weakness was noted in his body, and there was a reduced tone in the left side body muscle, and the reflexes are also reduced in the left side. Okay. So in the personal history, he was a non-smoker. Okay. And he was a retired worker, and he was keen at gardening. So he usually being there in the garden for the several hours in home during the daytime. And in the medical history, he had a atherosclerosis. And he was under the treatment of simvastatin, but he was not under proper medication and not under proper regular checkup. Okay. So and another medical history, he had a bilateral osteoarthritis knee. Okay. And surgical history, there was no particular surgeries done previously to the person. And the drug history, he was not taking any drugs other than the simvastatin. Allergic history, there is no known allergic history. Okay. So in this, what do you think? Why there is a patchy shadowing at the right base of the lungs, which was shown in the chest X-ray? Yes, accumulation of fluid in the lungs will usually be like a shadow one. Okay. So and in diagnosis, there is a aspiration pneumonia. It was stated that aspiration pneumonia. Okay. So what do you think? Why the aspiration pneumonia is associated with the right basal lobe?
Because I think he aspirated more when he fell down.
Yes, good. So as he said, he was fell down and his wife stated that this collapse has happened previously several hours before. So it was that time period that happened, the vomited content was taken inside without consciousness, so that there was an accumulation of the fluid that happened in the lung. So that is the aspiration pneumonia cause. Okay. So and the main thing is, what is the recognized risk factor for the stroke in this patient?
And maybe the atherosclerosis.
Yes, the atherosclerosis, he was under medication, simvastatin, but his wife stated that he was not under regular medication and also not under regular follow-up. Maybe the simvastatin was not adequate to the progression of the atherosclerosis. So atherosclerosis is a risk factor for the heart attack, which is a cardiovascular accident, and the stroke cerebrovascular accident. So in that case, the patient has to be very conscious in regular follow-up of how the progression has happened. But he missed out that. So that is the major recognized risk factor for the stroke. Are you clear? Yes. So now our role. So as a physiotherapist, we have to take care of a cerebral artery stroke cases from acute phase till the recovery. So in this acute phase, what are all the things we can able to do? What are the things we need to address?
In aspiration, you have to take suction.
Yes, one is the respiratory function rehabilitation. The next one is the musculoskeletal rehabilitation. Yes. So in the aspiration pneumonia, as he said, what and all we will do to clear out that?
Suction.
Yes, suctioning will do. Then chest physiotherapy, that will automatically dislodge the content and the infection will not spread to the other area. Okay. Then what are the things? Postural drainage. So postural drainage, suctioning, chest physiotherapy will be our main role in treating the aspiration pneumonia. So the next have to consider both aspiration pneumonia in notice during the positioning. Okay. Then what are the things, other things, musculoskeletal treatment? Yes, passive movements for only the affected side or the both the sides. Okay. So to prevent the deformities or contractures and to prevent any bed sores in the acute case, we have to give passive movements in both the sides. And once if the patient has recovered from the collapsed state and if the patient can able to some comments extra, we can able to make the patient to sit in a long sitting position. So during long sitting position, we have to monitor before and after vitals. Okay. Since there is a aspiration pneumonia, we have to check what are the vitals. We'll check respiratory rate. Yes. Pulse rate. Yes. Blood pressure. Yes. SpO2. All these things should be considered while sitting during, before and after, and we have to monitor and we have to record the vitals. Okay. Then only we can able to progress to the next step. So once the patient is able to sit in a long sitting and if the patient's vital is stable in the long sitting, then we can progress to high sitting. Okay. So high sitting also can aggravate some altered hypertension status or altered blood pressure. So throughout the high sitting, we have to continuously monitor the SpO2 and blood pressure. So after the coming out from ICU to ward only, we can able to progress to the next stage. And once if the aspiration pneumonia has settled and as the medications for the aspiration pneumonia has reduced with the dosage, we can able to progress in concentrating more on the musculoskeletal function. Okay. So this patient is not having any subluxation at the left glenohumeral joint. So that is our positive point. So what we have to do? We have to prevent the subluxation because there is a left side complete weakness. So we may expect subluxation at any time. So we have to position the patient accordingly, and also during shifting, turning, we should not drag the left arm. So even a simple drag with a moderate amount of force can aggravate what? Subluxation of the left glenohumeral. So in our physio role, there are two components we have to address. One is respiratory function, next one is musculoskeletal function. So this are the things we can able to do in the acute phase of the treatment strategies in this right middle cerebral artery stroke. Okay. So and right middle cerebral artery stroke more affect the upper limb than the lower limb. Okay. So we have to be more conscious on tone improvement in upper limb and the contracture preventions in upper limb and the task activities which are all needed after the discharge. So that and all we have to concentrate in this case. Okay. So that's all about this right middle cerebral artery stroke, students. Thank you for the cooperation.
Thank you.